Marion. I think we could almost stop the meeting there, because I think you've made the case for virtual cancer care reviews, and we don't need to go any further. When we did this webinar last week, your slide, Fiona, was the one that provoked most debate, and I think is certainly the most powerful. And again, I think Liz and I, as the other GP who's been involved in this project, were absolutely horrified when we first started this, and neither of you had actually knowingly received a cancer care review, and that sort of bore out some of our earlier work. So I'm going to introduce now Liz Towers, who's a GP in Mid-Essex, and she's actually going to talk about it from the existing QOF and medical perspective, if you like, and what we hope this project will actually add to standard cancer care reviews, which we've already had admirably demonstrated are imperfect, and as it was highlighted in the talk, a conventional cancer care review would not pick up 0.1% of the issues that you've raised. So Liz.
Thank you, Pete, and thank you, Lee, Marion, and Fiona, and just ditto what Pete has just said. Next slide, please, Martin. I suppose I just want to start by saying, you know, modern cancer care is just as much about services and care outside the hospital as it is in the hospital. You know, cancer has changed, and this first slide is really putting a cancer care review in the context of what has happened with cancer care. So if you look at the bottom line, you know, in 1970, your average survival for all cancers was a year. Move on to 2015 with better treatments, earlier diagnosis, screening, and we've now got average survival of 10 years. You know, the population of people living with cancer has doubled over the last 30 years. We are diagnosing more people with cancer. And significantly, I think as well, if you look at the sort of big bubbles above, because of this increasing aging population that we have, people are living with not only their comorbidities, but living with their cancers as well. They survive their heart attacks, they survive their strokes, they have more time to develop a cancer, because cancer still is predominantly a diagnosis that you get 65 years and over, not entirely, but certainly it is. 70% of cancer patients have one or more long-term conditions, so cancer is very complex. So good news story about survival rates, but there is more to this. And if we go to the next slide, living beyond cancer does not mean living well. And I think Fiona has articulated that and demonstrated that in her mind map. 1 in 4 of those living with cancer face poor health or disability after treatment. Over 70% need emotional support. And 1 in 5 people living with and beyond cancer have those unmet needs. And if we look at this a bit more closely, next slide, please, Martin. So again, 1 in 4 cancer patients must deal with consequences of their treatments. You know, people who've had pelvic radiation, continence problem can be really difficult. Fatigue can be really difficult. Cardiac problems. As I've said, 1 in 2 cancer patients have comorbidities, so they're dealing with that as well as their cancers. Many fear a recurrence of their cancers. But I think that the next figures are really interesting. So people with cancer are 37% more likely to be unemployed than the general population. 22%, 1 in 5 people living with cancer suffer with loneliness. We often don't even think about that as the medical profession. We think about their treatments and potential side effects, but nothing like this. Practical and personal needs and emotional needs. If you look at that, many do not have these needs addressed. So 65% have practical and personal needs. Fiona's alluded to a few of them already. 78% have emotional needs, and we know that psychological support is very poorly resourced. So if we go to the next slide, this is really where we talk about personalised care and cancer. And personalised care is something which has been a bit of a buzzword, but at its heart is absolutely looking at the patient and what their specific needs are, and that shared decision making. This wheel that you're looking at is quite old now, but it still holds true. Designed by Macmillan, and it was really talking about how do we support patients once they've gone through that active treatment. And as I said at the beginning, traditionally cancer has always been thought to be the secondary care speciality. Well, no, actually, it's now a speciality that should be in primary, community, and secondary care. So at the heart of it, they talked about treatment summaries. So as professionals, you know the diagnosis, the therapy, the treatment intent. Was it curative? Was it palliative? What the general outlook, potential adverse effects. Treatment summaries are a bit old hat now, because as we know, and we were just saying about cancer being a long-term condition, many patients go through multiple treatments. They may get a recurrence, and because of modern treatment now, they get further treatments. So actually it's not an end of treatment at all. It keeps going on, just like your diabetes care carries on. Health and wellbeing events were launched to really give patients the chance to meet others and to talk about some of their needs. Holistic needs assessment, so that whole bit, which again sort of is reflecting what Fiona was saying in her mind map: physical, psychological, social, spiritual, patient-centered care approach. We make too many assumptions in health that we know what's right for the patient. We have to turn that round and ask the patient, what do you need from us? What can I do for you? And then at the core of this for us today is this cancer care review. Next slide, please. So just to put it in context, an average practice of 8,000, probably the numbers are much bigger now as we're hemorrhaging GPs, but has got approximately 280 patients living with and beyond cancer, and it's set to double. Over half of those will be diagnosed over 5 years ago. We know the evidence is there that after a cancer diagnosis, people will attend more frequently than other patients of the same age, and they're often attending primary care and A&E, and that probably reflects those unmet needs. And as we've already said, they are experiencing consequences of their cancer or treatment affect their quality of life. And unless we have systems that can support them, they will bounce around trying to find that help and support. Next slide, please. So I'm sure most of you on this call know what a cancer care review is, but really, you know, at its heart, it's a conversation. It absolutely isn't a tick box. It isn't that diabetic review where you've got to fill in the blood pressure and you've got to do their HbA1c or whatever. This is a conversation, and it should be patient-led. They need to be able to talk about their cancer experience and concerns, understand what support's available for them in the community. And I am increasingly amazed at what's out there in the community with various charities, and to receive the information, because at the heart of this, most people want to get on with their life. They don't want to be defined by their cancer. They want to get on with their life. And well done, Fiona, by the way, for being the highest scorer in your wheelchair competition. They want to get on with life. Next slide. Just a reminder here. Sorry, next slide. About QOF. I'm sure you all know that. I mean, that 3 months after diagnosis, I think that is really key. And I think I would encourage those on this call to think about who is giving that call. It doesn't have to be the GP, it doesn't have to be a nurse, but it does need to be somebody who understands and says, how are you? Is there anything we can do for you? And if you haven't got the answer, somebody within your team can help. And obviously the sort of the primary care 12-month after diagnosis QOF indicator, where it's a much more structured cancer care review. Next slide, please. So the holistic needs assessment. So obviously this is filled out in secondary care. This is one of the Macmillan ones. And I would say that holistic needs assessments change. So one that is done at diagnosis will be look very different from 1, 2 years down the line, 5 years down the line, and we need to be able to, you know, encourage patients, you know, not that this is my HNA, it will change and we need to adapt to that. Next slide, for those who haven't seen it, but I'm sure all of you know, is we want you to be using the System 1 Macmillan template, which guides you through. But again, as I've said, this shouldn't be a tick box. So when people are invited in for their cancer care reviews, it should be that initial invite of, you know, look at your HNA, what's important to you now, what would you like to discuss? And if some of those boxes aren't ticked, doesn't matter. It really doesn't. I really want us to get away from that. Next slide. Thank you, Martin. And just really sort of picking up what Pete was saying. So we see a virtual group cancer care review as a way of bringing 10 patients together, all with a similar tumour site, who can talk to one another, who may be able to raise issues that they wouldn't otherwise. Often you've got one person in the group who'll start a conversation and others then feel empowered to talk as well. We want it to be patient choice. So if they want a one-to-one, they should be able to have that one-to-one. Flexibility, much better for a lot of people not to be dragged into a GP surgery with with long waits in the waiting room, but to actually do it from their own home. I'm sure all of us here today, we're in, you know, I'm at home here, but it's so flexible. But actually, if you're feeling a bit poorly, then much better to be able to do it from home. And as I said, sharing and learning from peers and onward support, signposting. So that's me whistle top tour about cancer care reviews. I'm going to hand you over to Charlotte now, who I will let introduce herself. Thank you, Charlotte.